Welcome to the EAU Podcast. Today's episode is the first to follow the EAU 26 Congress in London, where the latest EAU Guidelines updates were released. With the new edition now published, we take a closer look at how the EAU Guidelines on Urolithiasis are created, reviewed, and updated. We are delighted to be joined by our panel, Professor Andreas Skolarikos, Dr. Christopher Netsch, Dr. Otas Durutovic, and Professor Thomas Tiley. Thank you for joining us. Let's begin.
Good morning, good afternoon, good evening, or even good night once again. This is another EAU Education online content, and today we're recording another EAU and Urology section Journal Club edition. Today I have with me Professor Skolarikos, Professor Netsch, and Durutovic from different countries, and we will be discussing the EAU Guidelines on Urolithiasis. I think this will be quite an exciting edition today. We'll be talking about whatever is new in the guidelines on stones, but also and mainly on how those guidelines are developed, why some things are in the guidelines and why some things are not, what we can use them for and what we can't use them for, and what is missing and why. But I'll first let my panel introduce themselves. Professor Skolarikos.
Good morning, good afternoon, good evening to anyone. First of all, it is a great pleasure to discuss about the EAU Urolithiasis guidelines. I think it's very important. I'm Andreas Skolarikos. I'm a professor of urology in Athens, Greece, and I'm very happy to chair the panel of the EAU Urolithiasis. And I'm very grateful to all the panel members that they have developed what we believe is an explicitly guidelines of very high standard.
Thank you and welcome. Dr. Netsch.
Hi, everyone. My name is Christopher Netsch. I'm the head of the Department of Urology of the Asklepios Clinic Hamburg-Barmbek. And I'm happy to join this discussion and conversation and hope that we enlighten our audience on the new guidelines. And I think it will be fun.
And Dr. Durutovic.
Hello to all. I am Otas Durutovic, professor of urology at the University of Belgrade, Clinic of Urology, passionate urolithiasis guy, stone guy, developing stone surgery in my country, and recently, 2 years ago, founded the Department of Endourology. So we are now trying to develop technical part of in treatment of stones and also other fields where we can use modern technology, lasers for sure. And that's why I think it's very important, considering stones, to get in touch with the guidelines, because a lot of young guys are looking to the guidelines like Bible, first reading that to navigate them and to see if is it really helpful and how strict criteria to be in the guidelines are.
And I'm Thomas Tiley from the University Hospital of Ghent and General Hospital Mary Middle-Earth in Ghent as well. And I give the floor to my esteemed panel. Go ahead, Professor Durutovic, with the first question.
Andreas, let's start for the very beginning. How guidelines are developed and what is the way to develop something which will be recognized like recommendation?
Yeah, Otas, I think the guideline recommendations are mainly built to support real clinical decisions. It's not a textbook. So the idea is not to be a textbook from the beginning. So what we do is the panel reviews the literature in a very structured way and then turns evidence into recommendations, as you said, using a consistent decision framework. So that means that we have to judge the certainty and the quality of the evidence. We have also to judge the benefit and harms to our patients when we introduce a recommendation. We have to see the patient values, of course, and preferences if they are available in the literature. But also we have to come to a consensus wherever these values and preferences are not reported. Now, each statement actually is accompanied by documentation, and we call it strength rating forms. That these forms show actually how the panel weighted all the elements, all the literature that we get from our search. So this is basically what we do. We search the literature, in a structured way, as I said. We look about the certainty, but most importantly, of the quality of the evidence, and especially the benefits and harms of what we are suggesting or recommend within the guidelines. I have to underline that not only for the stone guidelines, of course, but for the guidelines in general, we do not replace the clinical expertise. And of course, nothing is mandated. We do not define, let's say, a legal standard of care, as we say in the guidelines group. I think this is quite important because a lot of questions that we get in congresses between friends from our residents is, why does not the guideline tell me exactly what to do in every situation? I think for every aspect of pathology, urological pathology, but especially for stone disease, there is a great variety. So we say that the guidelines is to guide, but of course, we do not replace the clinical criterion and the clinical expertise, as I said. Now, we do this procedure of reviewing the evidence, and as I said, in a very structured way, on an annual or biannual lately assessment of the newly published literature. And we have a very full update nowadays every 2 years, but also we have limited updates, as we call it, every year. And this is mainly how we do it.
So, Andreas, just one question. So what kind of evidence do we need to get changes into the guidelines, so to get a paper with a statement, with a strong recommendation into the guidelines?
Christopher, this is a very good question, actually, and this is the pain that we are getting every year between us, and this is also what we consider. I mean, that's why I'm happy, because I do have a panel of very expert stone surgeons, and not only that, we give suggestions. We always discuss about the quality of a randomized controlled trial and why we actually reject it or accept it. What moves the needle, I would say, is the evidence. First of all, is it important for the patient? The second is whether this evidence is consistent and really precise in the literature. So one only paper does not tell us a lot of things. We need to have consistency in our clinical practice. And of course, one of the main reasons that we accept a new change is if it is able to be generalized to the population for the average urologist, let's say. In practice, this usually actually means well-done randomized controlled trials, high-quality comparative studies, and of course, systematic reviews and meta-analysis. But especially for these systematic reviews and meta-analysis, only for those who show actually a reliable effect size on the outcome that we care about. Let's say for stones, we care about the stone-free rate, the complications, the retreatment rates, pain, quality of life, and so many other sepsis, the renal function, and so many other primary or secondary endpoints, as we say. Then the panel actually grades the recommendation strength, as I said before, based actually on the literature, on the consistency, but the certainty, as I said, which is very, very, very important for us. And of course, we also consider, even if I have a very good, high-quality randomized controlled trial, or if I have comparative studies, whether the patient will have benefit or will be harmed due to our recommendation. Now, why strong or weak recommendation as we have? The strong recommendation for us means that we have higher evidence certainty. So if I have a lot of randomized controlled trials well designed, then I will accept it. But not only this, we have to have a very clearly defined benefit to harm result for our patient. And if possible, but the PROM results are not that many in the literature for stones. If I have the patient preference, what the patient really prefers, but as I said, we don't have a lot on this yet in the literature, then that makes a strong recommendation. Now, weak recommendation means that I have the certainty of my evidence is lower. There is a wider variation in patient values or preferences. And I have also to say that based on the way that we have the tool that we are using to make the recommendation, as I will explain in 1 minute, we can upgrade or downgrade a recommendation from weak to strong or strong to weak based on the consensus that we're having within the panel members. And don't get me wrong, of course, if I have a good quality certainty of the evidence, we never downstage the recommendation, but we can upgrade a recommendation even if I don't have a huge evidence that's supporting, but it makes a clinical, it seems logical, it is clinically logical to do it. Now, the guidelines panels, we have used the modified grade approach in the recent 5 years, I think, emphasizing which the grade approach is how we create the recommendation. It's a 9-step procedure, very tedious actually, that we do for every recommendation. And that includes, in general, the evidence, as I said, but also if it is the certainty, if we have a lot of this evidence, if it can be applied to the vast majority of our patients and the vast majority of them will benefit from this recommendation and not have harm. So I think what is creating a new change to come in should have high evidence certainty and a lot of benefit to our patients.
Okay, thank you, Andreas. This was a great answer.
I would like to make a comment on what Andreas just told, because the main criteria for introduction, some studies and opinions into the guideline is whether it brings benefit or harm the patients. Let's say like that, very simple. So my question would be, why do some things get into the guidelines and others do not? Especially if we are witnessing many improvements that are happening and many tools that are used for years. So maybe we'll come to this question later, but definitely some things are getting into the guidelines and some don't. So Andreas, what do you say?
The easy way to say is that we have bad literature, but this is not right actually. It is the great variety of the clinical scenarios, of the cases that we are confronted every day, guys. We cannot put everything in a study, and the confounders, let's say, are so many that it's not possible. So we are not bad scientists, I would say. Of course, we do have some randomized controlled trials that we go through the consort criteria or the Oxford criteria, and we see that they are not fulfilled. So we just disregard these RCT because, RCTs are not all the same. But as I said, most exclusions are not because something is really bad. But I think that the grade that we have is not for the guideline as yet. I would put it in that way. So if I will give you some reasons, I would say is there is some, let's say, evidence uncertainty. So if I have a small study, small numbers, if through the literature search, a non-comparative study comes, if the results are inconsistent, if I have for a systematic review or a meta-analysis, an extremely high heterogeneity. If, as I said, the criteria for a good, well-prepared, randomized controlled trial are not fulfilled, then we don't accept it. Some studies you saw, there is, as we can call it, as a mismatch of the outcome. So I have a good surrogate endpoints, but the benefit for the patient is really unclear. I don't want to give examples, but I don't want to point the studies, but there are some studies that they have been very well designed, but the benefit for the patient is not there. I think if I can give you some other reasons, some studies, some results, let's say, depending heavily on the surgeon's experience, the center volume or the device generation or settings. We have to look at it on all these factors very well, because as I said, it's not only the certainty, but we have to be able to show that what we recommend can be used in a wide spectrum of the urologists outside in the community.
Yes, I think you said something really important and always focused on evidence of benefit. But what do you say about recommending what not to do? Because I think with some technical points, we are now facing really dangerous scenarios if tools come into the hands of unexperienced urologists. So what do you say about this?
I would say that we need, as I said, we really focus on the benefit to harm balance in our guidelines. We do recommend algorithms on how you should treat your patients, even if it is in the therapeutic way regarding surgery or in the metabolic evaluation of our patients so as not to reduce the recurrence. But we cannot say what not to do. We have in the guidelines, and this is quite new for the last 2-3 years, for every topic of the surgical treatment of our patients, let's say shockwave lithotripsy, ureteroscopy, or percutaneous surgery, we have the best clinical practice Otas. And this should be really followed, because we are actually quite proud, because that is from this panel. It is the idea of this panel, and we just wanted to make sure that every step that you are using in everyday surgery should be based on the best clinical practice. On the other hand, it's very difficult in the guidelines texture to say what not to do. Believe me, it's really difficult. As I said, the guidelines guide you, but on an individual base, you have to have your own criteria. I think the recommendations in our guidelines panels are about to be clinically important care decisions. That's, if I had to put it in a way, I would say it should be a decision that is clinically important. And I very, very often say to the panel members and that we have to identify fundamental questions and not any aspect of urology to do a systematic review, but we are the guidelines. We need to identify fundamental questions to answer through a systematic review or through the search of the literature. As I said again, the effect size, the certainty, the benefit to harm balance is very important. And we are looking forward to the new editions of our guidelines to have more evidence to use regarding the patient preferences.
So, Andreas, I just have another question regarding the guidelines and the structures, because we have this traditional structure in our EAU guidelines. In every guideline, let's say PPO, let's say stones. So, but what can we expect in future directions about the structure of the guidelines with regards to AI, or let's say red flags and green flags? So will it be structured in a complete different way in 4 to 5 years?
Christopher, superb question. Probably in 3 to 5 years or even earlier, probably the panel will be not a panel anymore. So probably the EAU office will put everything in an AI software, and actually better guidelines could be. But
You really believe it, Andreas?
well, I mean, yeah, I believe it. I believe it. Honestly, I believe it. The main reason is, of course, the AI and the computers and whatever, what we feed them, they will give us back. But honestly, I would say if we get the evidence from all over the world and high expertise, and we filter this evidence, then yes, Otas probably it will come with some ideas and proposals that I have not even thought about it. So yeah, I think this is a great tool. It is for us to decide how it should be. And I will let you know what the guidelines, the STONE guidelines will be involved to in the next year, I hope. It is supported from the EAU, money supported, financial supported, I mean. To get involved after the prostate cancer, we will be the first non-oncology or one of the first non-oncology guidelines to get involved with big data. So we will try a lot of work, I think, for the panel members. A lot of dedication will be needed. But yes, I think this is the way forward because let's be honest, in clinical practice, we design a randomized controlled trial, a perfect one, because as I said, a lot of RCTs are not of high quality. But let's assume that we have designed a high quality randomized controlled trial. And then we get the result. And what we do up to now, we extrapolate these results to every patient we see. Unfortunately, this is what we are doing most of the time in our clinical practice. This is the best evidence that we have. Now, in the era of the big data and AI, I think, yes, Christopher, the guidelines will, and the format, and of course the outcome will change, I think, tremendously. And as I said, it could be earlier than the 5 years time.
So, Andreas, you've definitely outlined how complicated it is to develop guidelines. And I think that a lot of people who read the guidelines who don't really realize what kind of work actually went into the development of this entire document. Because when you read the guidelines, a lot of these things make sense. You look at the summary of the data and you say, of course, yeah, we know that. We've read a paper or two here and there. We know that. And then the recommendations, most of them, or actually all of them, really make sense. And we try and apply these in our clinical practice to use the guidelines and do good work and be good clinicians. But the body of work that's behind that and the theoretical work that's behind that, looking at the benefit and the harm, the grade of recommendation and so on, that's massive. So I think it's a really important message to the listener that these guidelines are not just developed overnight. This is not just reading a paper and putting it into a document. It's really important to realize how much work went into it, how much we actually evaluate each study before we decide whether or not this goes into the guidelines. I think that's important to emphasize. So thank you for outlining that as you did.
Thomas, thank you so much for this, to underline this issue, because now and then I have some back home, but even internationally, some people, they are approaching us, and you know that very well, telling, okay, what are you doing, the guidelines? You don't have this, you don't have that. And I always say, guys, please provide us the evidence and publish your experience and your evidence, and then you will see it in the guidelines. That's number one. Number two, which is very important, and the guidelines have changed lately quite a lot, actually, because I'm involved within the guidelines, not as a chairman, but as a panel member for several years now. And yes, we didn't have the methodology in the past to create algorithms to make decisions and so on. But now we do have, as I said, a lot of methodology, and I'm very happy to say that I've been through and I learned a lot of things by using this methodology throughout these years. And honestly, as you said, and you know, Thomas, because you are in our panel and you are working heavily, it is a tedious procedure. We do not rely only on reading the paper, and it's just some people deciding what is good or what is bad. No, it's not like that. I dare to say that the search methodology that we are using could be better to the EAU guidelines, what they do, and to the NICE guidelines. And I know that it could be a lot of criticism on that, but I think we are doing a very good job thanks to the panel members. And of course, it's not only the panel members, because we have not underlined that we have a dedicated researcher that we give what we need every year, and the literature comes back through well-performed searches.
Andreas, I think you said at the very beginning something really important, to realize that guidelines are not the textbook. And that meaning that you have to read really a lot of textbooks to understand guidelines, because guidelines have to open space for a personalized approach to every patient. That means that you cannot open the guideline and navigate yourself. The guideline is just one additional tool for better understanding of limits in treatment.
I think you're absolutely right, Otas. And of course, the guidelines, as I said, is not a textbook. And for sure, if you want to be a dedicated endourologist and a dedicated stone surgeon or a dedicated stone urologist, then you should read the textbooks, you should read the papers published, and you should also read what is coming new in the technology, because our specialty is depended heavily on technology. The guidelines, what do the guidelines do? They do summarize everything. And actually, they do summarize it, as I said, in a way that the recommendation is for the patient benefit. That is a great job, I think. And what Thomas didn't say, and I didn't say either, is that we do not make recommendations on everything that we read. We make recommendations on fundamental questions that can be supported. This actually, you cannot find it in a textbook, not even on a paper, in a paper. So I think it's very important to have something to guide you in your everyday practice. To give you another example, a lot of people, and you know that very well, find the metabolic evaluation of the patient really difficult. While I was just a panel member, we started it with the algorithms that you see regarding the metabolic evaluation and how to reduce the recurrence rate of stone patients. And we came with diagnostic algorithms that you can follow and therapeutic algorithms that you can use. These two algorithms cannot replace, of course, a textbook for you to understand in depth the metabolic problem of your patient. But what they can do, make the life of the average urologist easier when you operate. To give you one simple example, you take a stone, you send it for analysis, and then you have to decide whether this patient belongs to a high or low risk for stone recurrence. We have specific tables inside that who is defined as a high risk to recur. And then, based on that, we say, do a specific metabolic evaluation. And the specific metabolic evaluation, if you ask the average urologist, may not know, may not realize that is a 24-hour urine collection. And then on the outcome, we have the diagnostic algorithm, meaning why this patient has hypercalciuria, what is the underlying cause. And then very quickly, what should I give? That makes the average urologist, who is not an expert like you, Otas, like Christopher or Thomas, to comprehend easily what they should do. And I think this is the magic behind the guidelines.
So the guidelines are magical. That's fantastic.
It is, Thomas. omitted.
That's the core message I take from you, from your last response to Otash's question. Thank you very much for that. I think it's also important to identify that you don't make recommendations for everything and highlight why. I think that's important because sometimes people will look at the guidelines looking for questions to everything that they do, and well, it's not in the guidelines, so. But it's important to realize why some things are not in the guidelines as well. So thank you for outlining that for us once again. Maybe another question to you. I'm excited about the guidelines, but I'm biased because I work with the guidelines. But for yourself and maybe for our listeners, what do you think are the most important or most exciting changes to the recent guidelines in stones? The ones that are already published and the ones that are coming.
I'm just laughing, Thomas, because I find every sentence in the guidelines exciting. Well, I could talk about these all day, let's say. And of course, I will miss some of the changes that we have. In the recent years, we created a great, according to me, follow-up algorithm for the stone patients after definitive treatment. And based on the restrictions that we have from papers and that they have been published up to now, we managed to do a systematic review and come along with an algorithm that can be easily used. And an algorithm actually that is based on the patient benefit to harm ratio. To give you an example, we do not recommend CT scans for the follow-up of our patients. We just recommend KUB and ultrasound unless we have to treat the patient. Of course, if we have to retreat the patient, then we need the CT scan. The main reason is to really reduce the radiation exposure of our patient without compromising the clinical outcome. The most important change that we have made in the last years is, as I said before, the diagnostic and the therapeutic algorithms in the metabolic evaluation of our patients. And actually, I think these algorithms are unique. They do include everything, and as I said, they make our lives easier. Very recently, we have a very good section on the genetics for stone disease and who we need to evaluate on this aspect regarding why they do create stones and why they have to be examined. I think we have me and Thomas Tahi have a great conflict all the time within the guidelines because Thomas is saying to me not only to me, of course, to the whole panel, okay, we have algorithms and the metrics that we are using are not good. We use only the diameter of the stone. Everybody discuss about the stone volume and why you don't change the algorithms because the stone is not only one diameter, is the volume that it is important to know, and so on. And actually, he's right. I have to underline, though, that the guidelines, the way to create the guidelines is not only our personal opinion. We are based on the outcome from the studies we have. So what we did, thanks to Thomas, we did a systematic review to see what is the outcome. And we saw that the areas under the curve probably support slightly the stone volume versus the stone diameter or the cumulative stone diameter. Then we have created a survey among more than 100 experts, not only Europeans, but overseas also. And we are in the process of analyzing. We did 2 rounds asking several questions because the evidence is not out there. So we need to create our own evidence. And we are in the process, and Thomas will make a comment on this, of analyzing the replies that we get. And then we have as a panel to decide whether we should change all the algorithms and replace them with the volume, or as I say, only to some extent. And that means that probably if I have a stone in the ureter, the stone volume will let me know whether I will finish early or not, but it will not change the practice. I will do ureteroscopy and laser lithotripsy. But we never know. We may decide with a stone volume algorithm for those stones 2 to 3 centimeters to decide whether it should be PNL or flexible ureteroscopy. So I think the new baby that we are planning and to incorporate into the new text, probably 2027, it will be to replace the metrics to stone volume. And now, as I said, regarding the diagnostics, for some years now, we have tables for everything from the normal values, blood exams, urine samples, whatever, to the side effects of the medications that we are giving, to the risk factors for stone recurrence. And another issue that we have incorporated quite lately, because we have an expert, we are not only urologists in the panel, we have an expert nephrologist and actually another affiliated nephrologist who supported the genetic section of our guidelines lately. So we have tables about the risk factor for chronic kidney disease and stones and end-stage renal disease and stones, because we all know that our patients are in danger for these situations. As I said, the big change in the future, I hope it will be our involvement in the big data analysis for stones. That is a tremendous work. We do hope that will take a lot of time of our lives as a panel. And of course, we will try to engage other experts on this, because it's impossible to be done only by 7 people. And of course, we are eager to see the money coming to this project, because of course, you can imagine we need the financial support for statistics, analyzing, gathering data, inserting data and everything.
Well, thank you so much for that. You know that I feel strongly about volume. We won't go into too much detail because I think this podcast will take too long. People will need to listen to the second half on their way back home, because the first part was maybe on their commute to work. I think we've covered quite a lot, actually, about how guidelines are developed, what is not in the guidelines, why things are not in the guidelines, why things take a lot of time to get into the guidelines, because let's face it, people have been talking about volume for, well, over a decade, and we haven't adopted volume as a metric in the guidelines yet, because we were just lacking the data, we were lacking the proof that is a better predictor that we can use in our algorithms. But let's wrap up this session, because I think this journal club has been quite interesting so far. If there is any final comments from my panel members, I would like to hear them right now. Christopher.
So I think, that was a great overview from Andreas about the guidelines. Yeah, from my point of view, I do not have any further questions. And you, Otas?
Yes, like you said, this is one good story, and maybe it's more clear now to people why some things, especially practical advices and technical points, are not emphasized, because it's really very difficult to say how to do things. And what I'm excited but also afraid is what is in front of us with this big mega project in the future about urolithiasis. I think we will have to work a lot, but I think the benefit will come out for our patients and for our younger colleagues, because they are our focus when we are talking about guidelines.
And Andreas, finally?
Of course, I have to give you some last metrics. Following the guidelines of prostate cancer and non-muscle invasive bladder cancer, the stone guidelines are the 3rd most read globally guidelines. And I do have to thank all the panel members for the excellent work they do. They like everything in life, they dedicate a lot of their time on this. I have to also thank the office, the guidelines office, because we do have a great support. Without them, it's not possible to work and organize things. And as I said, I'm eagering to see the new changes and the fresh ideas of the panel members that will come.
Thank you very much. Thank you very much to all three. And thank you very much to all our listeners, because you are the ones who read the guidelines and make us the third most read guideline from all the EAU guidelines. So thank to all of you. And if there's something that's not in the guidelines and you want it to be there, develop the proof and we'll consider it. And see you all for the next Journal Club.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.